Good afternoon, everybody. All right, I want everybody to turn around, take a look. This auditorium is packed. This is amazing. I am just over the top thrilled. We've been doing this nursing leadership series in partnership with UK Healthcare for about 3 years now. Dr. Rushton, you brought him in. So I don't know if it's that Johns Hopkins thing or the fact that she's an Eastern Kentucky woman that brought it. It's probably a combination of both, and that you are our alum. That's the main thing. So thank you very much for coming. So I wanted to let you know, if you don't know, I'm the Dean of Nursing. I'm Janie He, and it's really great to see so many of our colleagues here. It's truly an amazing outpour of support for our Nursing Leadership Lecture Series. In particular, I would like to thank our partners and nursing colleagues, including UK Healthcare, clinicians and leaders, the College of Nursing faculty, students, our alumni, our emeriti faculty, and a wide circle of friends and nursing leaders in the Commonwealth. So on behalf of Dr. Colleen Schwartz, my partner in crime, as you know, she's our Chief Nurse Executive and our Chief Administrative Officer, it is my distinct pleasure to introduce you and welcome home our distinguished BSN alumni, Dr. Cynda Hilton Rushton. She was one of our very first Distinguished Hall of Fame alumni in the College of Nursing. And all of our nursing students and all of our nursing faculty and alum, they know the famous wall, right? So you too can be on that wall. Cynda proudly claims her roots from Eastern Kentucky. She has established an amazing academic nursing leadership journey as an international leader and scholar in nursing ethics, end of life, palliative care, and moral resilience in the workforce. Dr. Rushton is the Anne and George L. Bunting Professor of Clinical Ethics in the Hopkins Berman Institute of Bioethics and the School of Nursing, with a joint appointment in the School of Medicine's Department of Pediatrics. A founding member of the Berman Institute of Bioethics, Dr. Rushton co-chairs the Johns Hopkins Hospital's Ethics Committee and Consultation Service. She co-led the very first National Nursing Ethics Summit in 2014, which was convened by the Johns Hopkins Berman Institute of Bioethics and School of Nursing. The summit, supported by strategic partners from 9 national nursing organizations and 7 collaborating organizations, developed a blueprint for the 21st century nursing ethics. Her current scholarship in clinical ethics focuses on moral distress and suffering of clinicians, the development of moral resilience, palliative care, and designing a culture of ethical practice. Dr. Rushton is the recipient of 3 postdoctoral fellowships. She has served on the Institute of Medicine's Committee on Increasing Rates of Organ Donation and was a consultant in its project When Children Die. She was once appointed the first chair of the Maryland State Council on Quality Care at the End of Life, has been recognized as one of Maryland's top 100 women, and is an American Academy of Nursing Edge Runner. She is a fellow of the American Academy of Nursing and a Hastings Center Fellow. Dr. Rushton is currently designing, implementing, and evaluating the Mindful Ethical Practice and Resiliency Academy, also known as MEPRA, and this is to build moral resilience in novice nurses. Her forthcoming book, Moral Resilience, Transforming Moral Suffering in Healthcare, is to be published by Oxford University Press, and this aims to transform current approaches for addressing moral distress by focusing on innovative methods to cultivate moral resilience and design a culture in healthcare that supports ethical practice. It is my pleasure and honor to welcome my friend and critical care colleague and our distinguished alum, Dr. Cynda Rushton.
So wow, it's really great to be here. I have to say, it's a transformed place from when I was here many decades ago. but it still holds a very important place in my own career. This is where I really started as a nurse in the pediatric ICU just across the street as a new grad. And at that time, it was pretty radical to have new graduates in an ICU setting. So I benefited from incredible nurse mentors, from the education that I received here, and I would have never, ever guessed what unfolded after. So I'm going to share with you a little bit about the work that I've been doing and am continuing to do. But before we get started, I wanted to invite everyone to reorient around why you're here. It's really easy, I think, when we find ourselves in this very complex, pressured environment that we can lose track of why we're doing the work we're doing. And so just to take a moment and remember why you chose this path, because it's actually a resource that can support us over and over again when we find ourselves in these really challenging situations where we're asking ourselves, what's the right thing to do? How can I be the nurse that I want to be? How can I be who I really am? So having that orientation as we embark in this time together, I want you to just start there. I'm going to begin with a case. And this is a hypothetical case, but one that might sound familiar to some of you. This is a case of Justin, who's a 27-year-old construction worker. He had a spinal fracture about 3 years ago that resulted in chronic pain. He was treated with opioids. When the prescription ran out, the physician refused to renew it, and that led him to seek alternative sources of relief. He started using heroin and developed endocarditis, which was insufficiently treated. He had many hospitalizations as a result of his endocarditis and other complications. And he was admitted to the hospital just 10 days ago with fever and positive blood cultures and was started back on antibiotics. He has been referred to outpatient rehabilitation on a number of occasions. He's had multiple relapses. And at the same time, the people taking care of him are very invested in his recovery. Each time that he's readmitted, they really pour all their advocacy efforts in trying to help him. He says he wants to get clean, and he has again agreed for an outpatient referral for treatment of his substance use disorder. Today, following a visit from one of his many friends, the nurse caring for him finds him in the bathroom, nodding, after apparent use of illicit drugs. So I want you to just notice what this brings up for you. Notice what your body does as you hear that story. Maybe you've had a similar situation. It might provoke certain kinds of emotional responses: sadness, anger, frustration. And often our mind has a narrative around cases like this, that we have come to have a certain kind of story about situations like this. So this is a situation where often one of the feelings that it provokes is helplessness. How do we actually serve in this circumstance? How do we make sense out of the choices of others? How do we understand what it means to be a good nurse in a situation like this? So think about your own responses. Sometimes what we do is we just numb out and we go through the motions, we check off the boxes, but we actually aren't there. We can become angry, we can distance ourselves, we might avoid patients like this. We could become very angry, frustrated. We might blame people, we might blame him, we might blame the system, and a whole host of possible responses. So noticing what those responses are very, very important, because one of the ones in a more extreme circumstance can represent moral outrage, especially if you've been in a situation where this has recurred over and over again, where maybe you've taken some efforts and it hasn't resulted in the outcome that you want. So moral outrage is the anger that is provoked by a real or perceived violation of an ethical standard, such as fairness or respect or compassion or beneficence. And often moral outrage is associated with a kind of energy that drains us because of the sense of frustration, sometimes disgust, powerlessness that we associate with the situation. And often what's at stake in these situations is there is at some level a threat to our sense of identity and integrity, our sense of self-worth. How can I see myself as a good nurse in this circumstance? How do I actually work with a situation that is largely out of my control? And how do I work in a system that may create barriers to getting exactly what this person needs? And I am not in a position to change that. Sometimes it can even challenge our beliefs, our values that are really fundamental to who we are. So all of these responses, I think, reflect the fact that we have, as human beings and as nurses and future nurses, we have obligations to serve others. And so what's at stake often is, first of all, respect for the person that we're caring for their family, but also for ourselves. So when we think about Justin, how do we respect him in the midst of this circumstance that he's in? How do we honor his choices and provide dignified care, even when we don't agree with those choices? How do we promote patient well-being and relieve suffering? And as I think about a case like Justin's, there's a very strong impetus for us to relieve suffering, his suffering, the suffering that is part of the disease process that he has. And to sometimes feel like we are participating in inflicting harm. Are we enabling in some way this process that is causing harm to him? There's also huge questions about justice and fairness, how we allocate our scarce healthcare resources. How are we fair? Are we treating similar cases in a similar way? If Justin's story was changed a little bit and he wasn't a construction worker, would we feel differently about him? If we changed some other factor about him, would that change how we show up or not? And this question of how do we actually have access to care for different types of services based on people's ability to pay or the severity of their illness. I think the bottom line in all of these situations turns out to be integrity. What does integrity mean for Justin? What does it mean for the professionals who are involved? And what does it mean for the institutions where we practice? So often what happens in cases like this is that when we find ourselves in a situation where there's two competing demands, neither of which we can actually meet without partially rejecting the other. So on the one hand, we want to do good, but sometimes that is balanced against resource allocation. And so if we choose to prioritize resource allocation over how much good we're going to do, it doesn't erase the fact that there's an obligation to do good. And so what that does is it creates a kind of residue, that unmet obligation. And it sometimes can ignite guilt and shame and regret. But there's also residual that comes from situations where people experience moral distress, where they have either compromised their own integrity or their integrity has been compromised by others or the situation that they're in. So I would argue that when we are out of integrity, we suffer. And it's interesting because our work as clinicians is largely focused on relieving the suffering of others. And we rarely pause to take account of the ways in which we are suffering. We are human beings too. And situations like this ignite suffering in us. I actually would be more worried about us if it didn't, because that would suggest that we are totally detached. We are unconcerned about situations where our attention is needed. So, for many years, I have worked in this area of moral distress and the idea of moral suffering. And where I've landed so far is that moral suffering actually is the sort of umbrella term that reflects the anguish experienced in response to moral harms, wrongs, failures, or unrelieved moral stress. So that's a pretty big tent of things that might fit in that category. And moral suffering can be triggered by a variety of things. It can be triggered by witnessing situations that one has not really created ourselves, participating or directly precipitating situations that cause a whole range of negative moral outcomes in some way or another. So with this as the sort of umbrella, the type of moral suffering that we've spent the most time studying is moral distress. And this is a concept that actually began in nursing. It has had a tremendous amount of research that has been done about the concept. It is now being examined in other professions and validated that not only nurses, but other members of the healthcare team are experiencing moral distress. So moral distress is the pain or anguish that affects our whole being in response to situations where three things are present. First, we recognize there's a moral problem. Secondly, we acknowledge that we have responsibility to do something about it. Third, we have gone through a process of discerning what would be the right, the ethically correct thing to do, but yet, either because of internal or external constraints, we're not able to act on it. And the bottom line is that then results in a threat or a violation of our integrity. So let's think about Justin for a second. The moral problem. What's the moral problem? What's the moral problem in Justin's case? We're trying to help, yes?
I think the crux of it is it's a conflict between personal value systems and professional value systems, and that's what causes the distress in a lot of nurses.
Okay, so here, if another way to maybe say that is his individual choices are in conflict with our professional values that are guided by our responsibility to help people, to promote good, and to relieve suffering. And yet, some people would argue, is he fully competent to be able to make the choices that he appears to be making? And we feel a conflict there. We have a responsibility to stay in relationship with him even if his values are different than ours. And this is where the rub comes, right? Because as a nurse, the first provision of the ANA Code of Ethics says we care for every person, irregardless of any personal characteristic. It doesn't say that we can opt out if we don't agree with the person's choices. And yet those choices may be fundamentally at odds with our own values. Right? It's a big requirement. And yet, that's where we are. We may reason about what the right choice is. You want to help him get to services that he can benefit from. You take a lot of effort to try to make that happen. And through no fault of your own, it doesn't happen. And so we end up feeling as if we failed somehow in these situations. So this sense of distress, that gap between who I am and how I am being in this circumstance, is a weight. It's a kind of suffering that we experience. In the literature, looking at the causes of moral distress, it's very clear that one of the main sources of moral distress has to do with end-of-life decision-making. In a recent study of critical care clinicians, not just nurses, but doctors and nurses, about 40% of their moral distress was about end-of-life decision-making, where they're being asked to continue treatments that they believe are no longer useful, where family members are asking for treatments that may be contrary to what the patient would have wanted, situations where people feel that the treatment is futile or medically ineffective, poor communication around goals of care. How do we understand what this person would want? Where we believe that what we're doing is merely prolonging an inevitable death. See somebody nodding up here. Yes, this sounds familiar, doesn't it? A big theme is also around communication and communication with patients and their surrogates about goals of care, about how we provide choices and sometimes how we disregard people's choices based on what we think is the right path. Incomplete or inaccurate disclosure, not being fully transparent about the options. We were just talking about LVADs and whether people actually understand the consequences of what the treatment involves. In some of our later work, the issues around unsafe or incompetent care of different clinicians has emerged as another important source. One that has been present throughout all of the research is around interprofessional conflict and authority differentials. And these last two, in the last, I would say, probably 6 or 8 years, has begun to emerge as a very significant source of moral distress. Inappropriate use of healthcare resources and situations where clinicians feel they are not able to provide optimal care because of external pressures, either from insurers or others, to reduce costs. So I want you just to pause on that for a second. Anybody in this room experienced moral distress? Raise your hand. What we know about it is it has a significant cost. It is significantly associated with burnout. It's negatively correlated with ethical workplace climate, so moral distress goes up as the quality of the workplace goes down. It has been repeatedly validated that it's associated with people leaving their role or the profession. Nurses, not surprisingly, across the board tend to have higher levels of moral distress than physicians, although physicians' numbers are on the rise. And in nurses, it's inversely related to years of experience. And this is an interesting one. What we think is that people who are new in practice and nurses who have been in practice for the longest period of time are probably the most vulnerable. And The longevity question has to do with what's called the crescendo effect, where these issues pile up and pile up and pile up because they've never been accurately or appropriately addressed. So, I have been in that space for a really long time. And I had the opportunity to be a visiting scholar at the Brochure Institute in Switzerland about 3 years ago, and I had a time to pause. And so I looked at all of the data again, and I kept asking myself, why are we making no progress in this phenomena? What is missing? How can we begin to, yes, we have a very serious problem. What are we going to do about it? So I began to explore this notion of moral resilience. And it was interesting, it was kind of a throwaway term in a few articles, and I thought, I wonder what that is. So I started, researching it, trying to figure it out. And I'd like for you to think about, we've talked about these hard, challenging situations. I want you to think now about a time when you were actually able to act with integrity. When you did the right thing for the right reason. And consider, what inner resources did you draw on when you were in that situation? Who or what external resources supported you? Did you do it on your own? Did you have somebody around you? What did that look like? So, what I believe is that all of us have the seeds of moral resilience. We have the resilient potential. And the question is, how do we water those seeds so that we can be in these inevitable situations without so much cost? So this is the working definition, and I'm hoping many people will continue this work and refine and expand. The capacity of an individual to sustain or restore integrity in response to moral adversity. And what I want to point out here is this is not a suggestion of being complacent. It's actually quite the opposite. Integrity requires a strong back. A spine of integrity is about knowing who you are and what you stand for and being willing to defend it. It's also not making nice about a positive spin on a difficult situation. It in no way suggests that we should deny the reality of moral distress. In fact, it is the fuel for us to explore what does it mean to be truly morally resilient. So we undertook a process of, we collected about 184 definitions of moral resilience from interprofessional clinicians, and we came up with these themes as the elements, the capacities of moral resilience. And I'm going to go through each of these briefly. But it starts, and what was interesting in the themes from the definitions is that integrity, personal integrity and relational integrity is really the grounding for moral resilience, along with self-regulation, moral efficacy, and self-stewardship. So I'm going to talk about those individually. So when you look in the literature, most of the time what we talk about when we talk about integrity is personal integrity. This sense of being a whole person, to be aligned with our values. This idea of being undiminished in the midst of whatever's happening around us. Instead of talking about our values, it's actually being them. And being able to do what's right even when it's difficult. And sometimes that means that we have to act in the midst of hard situations where there might be consequences and costs to ourselves. What was interesting in the themes and in the definitions was there was this second element of integrity that we called relational integrity. We work in teams. We work with patients and families. And so there's this idea that there is the embeddedness that we have with each other, that we're interconnected with each other, and that we could be whole and still be in relationship. So think about Justin. I can be whole in my values, and I can allow him to be whole in his. And that relational integrity is bi-directional. Think about it this way. If someone that you're working with has integrity, they do what they say, they live their values, that kind of energy and that kind of behavior is contagious. So is the opposite. When people around us are acting out of integrity, it's more likely that we're going to begin to adopt those very same practices. And pretty soon they become normalized and we don't even notice any longer that they're out of alignment with our integrity. So this idea of relational integrity is very important when we think about how do we show up in our work. It means that we have to be able to be more flexible and not so attached to our own point of view, to be accepting of other people's points of view. And this is a huge area for us, I think, to explore. Kaz Tanahashi is a Japanese calligrapher and translator. And I had been doing some work in Japan and was using the word integrity, and they had a hard time translating it. So I said to Kaz, I said, well, how do I explain this so that it can be translated? So Kaz made this Enzo with Japanese characters, and his definition of integrity is whole oneness. So what that suggests is that all of our integrity is interconnected. It's not just me and you. It is all of us together. Our integrity is fundamentally connected. So having integrity means that we've got to be able to discern what the right actions are when there's a threat to our integrity. And sometimes what we need to do is we need to be conscientious and find a way to compromise. Second, sometimes we need to bring our voice forward, conscientious criticism, to be able to raise the question about the injustice in the system, about assumptions that people might be making. Imagine yourself taking care of Justin and getting a report from a colleague who called him a druggie or some other label. Sometimes we need to pause and respond to those examples of disrespect, to bring our voice forward. Sometimes we need to refuse to participate, to remove ourselves from the situation. And in healthcare, the request not to participate is not a guaranteed that you will have that request honored. Because in healthcare, we must always continue to provide care for our patients. We can't abandon our patients. So if everybody said nobody wants to take care of Justin for reasons of conscience, we would unlikely be able to honor that in that moment because we have a primary obligation to our patient. At the same time, we need to have an environment where people are supported and able to bring those concerns forward and for them to be taken seriously. Sometimes in very egregious situations, we need to blow the whistle to bring in outside voices and analysis. I would say in this count, that ought to be far down on our list and thought through very, very carefully about the consequences to oneself and to others. Because sometimes whistleblowing is a response to moral outrage that can actually cause more harm than good. The final one is sometimes we need to leave situations. If we're in environments where we're constantly being asked to compromise our integrity, it may be that the cost is too high, and we should find another place to take our gifts and talents and use them. Next is buoyancy. And buoyancy is a very interesting concept. A lot of times when we think about resilience, it's about bouncing back. But what was true in this data was there was something more. Buoyancy is actually being able to bounce forward. So what we're looking for is how do we keep ourselves in this resilient zone when these situations occur? Because we know that there are times when we're going to be bumped out of our resilient zone. So a situation like Justin's might bump us out of our resilient zone. And so being able to be buoyant in the midst of a situation that bounces us out of our resilient zone, where we're stuck on high or stuck on low, is what is needed to be morally resilient. So I want you to think about bamboo. Strong roots, flexible, above the ground. It doesn't mean that anything goes. But we've got to be able to withstand the pressure of the things that are going to be in front of us in order to be able to continue to serve. So self-regulation and self-awareness starts with a foundation of mindful awareness. And mindfulness has become kind of a buzzword these days, and some people associate it with certain types of frameworks like Buddhism. Mindfulness is really about bringing yourself into the moment. You don't have to believe anything to be mindful. It's about training your brain to pay attention in the moment with caring intent. That's all it is. It's pausing, a place of stillness. That's what mindfulness is. And so it's a place that we can develop the neural pathways so that when we are in situations that are challenging, we have a skill and a practice to bring ourselves back into balance. That's what mindfulness is all about. And your breath, by the way, is a very handy tool to use, because it's the one thing that operates without any instruction, and it is one you can control. So try this. Everybody take a deep breath. Hold at the top, and then exhale slowly. What do you notice? That is our parasympathetic coming online. Our sympathetic gets all excited and, really jazzed up. Our breath can pull the parasympathetics online for us and help calm the nervous system. So mindful practice is very important, and I love this quote by Susan Sontag. The nature of moral judgment depends on our capacity for paying attention. A capacity that inevitably has its limits, but whose limits can be stretched. So mindfulness is important in an ethical conflict to allow us to focus our attention on what matters. If we are all dysregulated ourselves, it's unlikely that we're going to be able to detect what really matters in that circumstance. We're more likely to project. We're more likely to put our own points of view into the equation in a disproportionate way. So this idea of self-regulation and self-awareness is an important foundation for moral resilience. Moral efficacy is also one of the capacities. The belief in our ability to bring about the desired and beneficial results through one's efforts and our ability to exercise our moral agency. It is infused with a confidence and a capability. So I think we have often reduced ethics to this little thing that we do over there. Ethics is part of everything that we do. It is not separate from who you are. Your ethics your values are being exposed every moment in what you say, what you do, what you choose not to do. And so we need to feel that we have the capacities to recognize these situations, to work with them with skillful frameworks so that we can make sure that we are acting not from reaction, but from actual deliberation and discernment. And it is, in fact, the embodiment of our values, our ability to perceive the issues and to actually go from knowing what's right to actually doing what's right. So in many cases, our discernment, our moral efficacy invites us to take action, and often in response to reestablishing a moral value or standard from a place of stability and discernment. Having moral efficacy also requires courage. And courage, if you look back at the translations of the word courage, courage is about heart. It's about our innermost feelings. It's that resource that we can draw on to stand by our values. It is our capacity to befriend our fear and to stand up for our core values and principles, that we can actually feel confident that we can act in alignment with them. It does require a choice, and not always does it need to be a heroic choice, but it does require us to deal with our fear when things are unfamiliar, uncertain, where we are not sure what to do. That part of our brain, remember that, the amygdala? Do you know that part of your brain? That's in your most primitive part of your brain. When fear shows up, the amygdala is probably going to get activated. And that is likely to produce fight, flight, or freeze. We also know that when fear is present, the cerebral cortex goes offline and we are not able to think so clearly. We're more on autopilot and more likely to become rigid in our thinking. Our focus often narrows, and the likelihood of judgment, doubt, and blame surface. So we want to recognize when the amygdala is taken over and have some skills for how to bring ourselves back into balance. The final piece is about you can't pour from an empty cup. You have to take care of yourself first. So this idea of self-stewardship is an important dimension of moral resilience. It embodies a commitment to know ourselves, to know our limits, to know what we need, how we can manage our own resources, our energy, and to respond to them with compassion. How many of you have a personal resilience plan? Raise your hand. Raise your hand high. I don't see very many hands. So, interesting. Let me just offer this little piece of encouragement. The ANA Code of Ethics in the 5th provision says, the nurse owes the same duties to self as to others, including preserving integrity and well-being. I would say to you, it is not optional. And if you want to sustain yourself in this profession, you need to think seriously about what do I need to be doing to take care of my precious resource. You can't give what you don't have. And as a student, this is the time to practice so that when you are in practice, you will have skills and patterns and tools and resources to draw on. So I'm going to tell you just really briefly about MEPRA, and then we're going to stop. This is the Mindful Ethical Practice and Resilience Academy Janie mentioned. It's focused on areas of mindful practice, ethical competence, and resilience. It's a 6-session, 4-hour each program. It's very experiential. We do a lot of dyad work and go to the sim lab and practice having really hard conversations and being advocates and really learning about ethical competence. Let me also, whoops, did that? Is it going to play?
MEPRA, for me, sort of redefined the importance of acknowledging the multi-dimensions of what it is to be a bedside nurse. We are the catalyst for the healthcare team. We are at the bedside, and we really have the ability to sort of unite everyone together in these very difficult moments.
I really feel like it gives me the courage to speak up, but it actually just gets me excited about wanting to kind of be that go-to person. So having that ability to not fear speaking up, having the courage, having had the practice, wanting to be kind of like a go-to with your fellow nurses. I mean, even the senior nurses, I mean, discussing ethical dilemmas isn't always the easiest thing. So even though you may have 10, 15, 20 years of experience, doesn't mean you're still comfortable speaking.
As somebody who's precepted a lot of nurses now and been a critical care nurse for 10 years, it's impossible to not get burnt out. And this has been the greatest breath of fresh air in my course of being a professional nurse. It really lets you take stock of what's important in your life and why you got into this job in the first place, and gives you a voice to be a leader in the clinical environment, not only in ethical situations, but just in challenging situations as well. I think my favorite part about this program is that your brain and your mind are also connected to your body, and that when you learn to integrate your feelings, your thoughts, and emotions into your somatic being, it really makes you a more present and more capable professional and I think human being. Meditation has really reminded me of the nurse I want to be, that I want to be the person who can tune in and focus on the patient and really listen to what they need from me today.
So I want to just sort of round out our conversation. We've talked a lot about moral resilience as an individual strategy. But I think it's really important to recognize that that individual part of who we are needs to be leveraged towards system change. It starts with us. Our organizations are full of individuals, and that's all of us. So if we can bring our integrity, if we can bring our skills together collectively, we have to, at the same time, engage in system reform. It is not enough to be morally resilient as an individual. We have to work with our partners in the institutions where we practice to create cultures that actually enable us to have integrity. And that is not a small job to do. And yet, there's a collective power in those of us coming together with those same intentions to begin to make small changes that will result in big waves when we're together and aligned in our efforts. Another part of the Code of Ethics for nurses is in the 6th provision, which says that nurses have an obligation to contribute to a culture of ethical practice. So it's not someone else's job to create that culture. You are part of that culture. And so, as we often talk about in our MEPRA program, just because what you're seeing around you is not how you want to be, doesn't mean that you can't stand in your own truth. You can be the catalyst. Sometimes it's asking a different question. Sometimes it's listening differently. Sometimes it is initiating a pattern, a change in a pattern that is keeping us stuck in the way we've always done things. We have to learn to say why. Why are we doing the things that we're doing? Is there really evidence to support them? Are they actually serving the people that they're meant to serve? And if the answer to that is no, then we ought to be prepared to engage in a process of discovering alternatives. So, thinking about the complexity that we're in our healthcare system, in our world right now, it requires all of us to show up fully, to harness our individual and our collective integrity to do the right thing. So when you think about Justin, think about what's my part in that process. Some of you may go to Frankfurt and share stories like his as a way to influence policymakers about funding for those kinds of programs. Some of you may decide that you're going to just show up differently when you take care of him. Whatever it is, do it wholeheartedly. Thank you.
Hi, my name is Noe. I'm a veterinarian by profession. And rather than a question, I had a comment that I would like to share with you and the audience. In a previous life, my previous job, I had a lot of moral stress to the point in which I had to resign. And until today, about 11 years later, I still struggled with the idea that quitting my job was quitting my patients. And today, you have given me a different view. And for that, I thank you.
I want to say something in response to that. I think that very often we are very hard on ourselves about the hard choices that we have to make. And I think it's really important to separate our effort from the outcome. Because if we appraise our own self-worth, our own integrity based on the outcomes, many of which we cannot control, then we feel like we're out constantly failing. And I think that it's really important to think about Justin, how many times we tried. All of those efforts count, even if the outcome is never the one that we want. Because if we overlook that, then we are actually overlooking our own conscientiousness. And when you say sometimes we have to leave, that is a really heavy burden on us as nurses, to think that if I'm not here, the people who are going to suffer are our patients. And there's some truth to that, but there's also the other side of that. As our colleague Gladys Campbell often says, if we are constantly putting our fingers in the dike of a broken system, we are not allowing the system to be able to heal and be fixed, because we're creating the illusion that the system is working when it's not. So it's a heart-wrenching trade-off, but at the same time, integrity does require us sometimes to have to make those tough choices. So, thank you.
So with that,